Hey there, I'm Professor McBride, labor nurse, OB instructor, and your guide to everything OB. Let's get to it. In order to discuss preeclampsia, we should first start by talking about hypertension. Hypertension is blood pressure greater than or equal to 140 systolic or 90 diastolic, occurring on two or more occasions that are more than 4 hours apart. If a pregnant client has high blood pressure greater than or equal to 140/90 prior to 20 weeks gestation, she is considered to have chronic hypertension. If she had normal blood pressures at the beginning of pregnancy and has now developed high blood pressure greater than or equal to 140/90 at or after 20 weeks gestation, this is considered gestational hypertension or being caused by the pregnancy. Just because a woman has chronic or gestational hypertension does not mean that she will develop preeclampsia, but it does increase her risk, and we monitor these patients closely. For preeclampsia is a progressive disorder that originates with the placenta. So this happens all the way at the beginning of the pregnancy when the placenta is attaching, developing, and tapping into the maternal blood supply. Something in this process triggers an inflammatory response that can affect multiple organ systems for the mom. So we can see generalized vasospasms, poor tissue perfusion, and increased peripheral vascular resistance, which ultimately also increases the blood pressure and affects the way we perfuse the placenta, the way we perfuse the kidneys, everything. In addition to this, the cells can become leaky because they have increased permeability. So that's where we can see an increase in edema as well. So in order to diagnose preeclampsia, we're going to see the hypertension, but we're going to have at least one other symptom related to the organ system or systems that are being affected. And depending on the symptoms, we could have mild or severe preeclampsia. So additional symptoms could include renal insufficiency, cerebral symptoms, impaired liver function, thrombocytopenia, pulmonary edema, and hyperreflexia. So things we might see on assessment. Depending on the severity of the preeclampsia, it will affect what we might see and which organ systems are being affected. With severe preeclampsia, we're going to see blood pressures that are much higher, greater than 160 systolic or greater than 110 diastolic. And then the other symptoms are more severe, like greater proteinuria, headaches, visual disturbances, and so on. So for the renal system, proteinuria is a big thing we see with preeclampsia. And so protein creatinine ratio greater than 0.3 is diagnostic for this. We can also see increased serum creatinine greater than 1.1. And with severe preeclampsia, we might also see oliguria as well. Liver function is affected, so we could see elevated liver function tests. So the AST and the ALT may be elevated. And the patient can be experiencing right upper quadrant pain or epigastric pain related to the liver. Neurologically, headaches are common, so these are not treated with Tylenol or hydration. She still has the headache. Visual changes like blurry vision, spots before her eyes, also hyperreflexia. So if you elicit a deep tendon reflex, it can be very brisk. You might also see something called clonus, where if you flex the foot and then let go, instead of it relaxing, it twitches until it gets to the point that it relaxes down. And the number of times it twitches are the number of beats of clonus. And the more clonus you have, the more hyperreflexive she is. Then we can also see thrombocytopenia. So these are platelets that are less than 100,000 per microliter. And in severe preeclampsia, we also can see fetal growth restriction because it's affecting the perfusion to the placenta over time. And sometimes this can be significant. So our goals for our patient that's preeclamptic. A big goal is to prevent a seizure. Preeclampsia, pre is before, and eclampsia is a seizure that can happen, and we would like to prevent this from happening. The main medication that we use to prevent seizure activity with preeclampsia is magnesium sulfate. Magnesium sulfate is a central nervous system depressant, and it's given typically IV. It could also be given IM, but it's harder than to control that. So giving it IV gives us the opportunity to turn it off if we need to, if we see signs of toxicity. Because that this medication is going to take the excitability of her neurologic system and bring it down a touch, that's what we want. But if we depress things too much, we can cause severe symptoms like respiratory depression, absent deep tendon reflexes, lethargy, somnolence, things like that. So we're doing frequent monitoring and assessing her neurologic status at least hourly. And we have on hand an antidote in case she does show signs of toxicity, and our antidote is calcium gluconate. We're also watching her urine output because magnesium sulfate is metabolized through the kidneys. And remember that with severe preeclampsia, we could see oliguria. And we really need that urine output to be greater than 30 mLs per hour for her body to metabolize through this medication correctly. So we're watching the urine output as well. And then the other thing that we're going to need to consider is that with magnesium sulfate, we're going to be giving this to our patient from the time that we start it until 24 hours after her baby is delivered. And so for those 24 hours postpartum, the magnesium sulfate can have some effect on the contractility of the uterus in the postpartum period because it can decrease the contractility. And in postpartum, we need the uterus to contract to control bleeding. So we're also monitoring for that as well. We're going to be managing her high blood pressure. So the magnesium sulfate can have some effect on the blood pressure, but it is not the most reliable way to manage her blood pressure. So if she continues to have blood pressures that are greater than 160/110, we're going to be giving other medications. And the medications we typically use here are labetalol, nifedipine, and hydralazine. Labetalol is given IV. If we don't have IV access yet, if she was just admitted and we have just diagnosed her preeclampsia and we haven't gotten an IV yet, nifedipine can be given PO to start to bring that blood pressure down. Labetalol tends to be the medication that's used most frequently once we have IV access, but hydralazine is also a good other alternative. And then we're monitoring and we're preparing for the possibility of delivering. And so we're watching our fetal status. If the patient's on magnesium sulfate, this does cross the placenta to the baby. And since it's a CNS depressant, we can see minimal variability on our tracing because it can have a sedative effect to the baby. We're watching mom's vital signs. We're looking to see if her hypertension is being well managed, and then we're watching for worsening symptoms. If we plan to deliver, which most often that it will be the plan depending on gestational age, then we also are considering what else needs to happen related to the baby depending on the gestation. So to review, hypertension is blood pressure greater than or equal to 140 systolic or 90 diastolic on more than one assessment, at least 4 hours apart. Chronic hypertension occurs before 20 weeks gestation, and gestational hypertension begins at or after 20 weeks gestation. Preeclampsia is hypertension and at least one other symptom related to whatever organ systems are being involved. This could include the renal system, so maybe proteinuria, oliguria, increased creatinine, the hepatic system, including elevated liver function tests, right upper quadrant pain or epigastric pain, the neurologic system, including headaches that are unrelieved by treatment, visual changes or disturbances, and hyperreflexia. And we can also see thrombocytopenia. Treatment for preeclampsia includes preventing the seizure. And so this is going to include magnesium sulfate and all of the things that go with that, managing the blood pressure and keeping it in a safe range for our patient, monitoring for worsening symptoms, and being prepared to deliver the baby. Thanks for watching. Be sure to subscribe, like, and share for new videos every week about everything OB. See you soon.